come up on. We're now live, Chair.
Thank you, Kirsty, for your endeavours on this one. Are members okay to continue on this meeting? Yeah. No,
yeah, although Kath appears to have just fallen off.
Right, okay, let's continue. Let's start the meeting. It could be one of those meetings that we have a few issues. So anyway, welcome members, officers to the Adults Health and Social Care Scrutiny Board, Thursday the 5th of October 2023. If you've been logging on, we've been having difficulties. So if you are logged on, you're members of the public are most welcome. So welcome once again. So let's get on with the agenda. So substitutes nominated for this meeting and apologies for absence. I've got no substitutes and no apologies.
That's correct, Chair.
Super, thank you, Janet. Item number 2, members' interest, for members to declare their interest at the relevant time. Item number 3, admissions to the public. It's not recommended to exclude the public, and once again, apologies for anyone who's been trying to tune in. We are now live thanks to Kirsty's endeavours and rebooting a computer system. So we are having a few technical issues tonight, so hopefully that won't continue. So item number 4 is minutes of the Adults Health and Social Care Scrutiny Board held on the 31st of August 2023. I move those as a true record. Do I have a seconder? Councillor Hutchinson.
Yeah, can I just point out that there were a couple of actions agreed of follow-up meetings which haven't made their way onto the work plan yet, but are recorded in the minutes. So I was wondering if now is the time to address that, or when we're discussing the work plan.
We can discuss it now. I think it's relevant.
Okay, so it was agreed for a follow-up review on discharge to assess, because we didn't have any input from Health Watch or any other bodies to give us a wider perspective on how well that's working. And then it was also asked for a written report on the charging policy to be brought to a future meeting of the board, and that hasn't made its way through either.
Indeed, that was, so we agreed. Originally, we were going to have that particular item come back to this meeting, is my understanding. But what we decided, actually, the comments fed through from Kate and her group will be fed through to officers in the next few days to fit in with the consultation. So it's picked up, and then we'll it's our next following meeting is my understanding. But he just needs to update the work programme accordingly. I think, Councillor Hutchinson.
Thank you, Chair. Saving that, I'm happy to second.
Yeah, superb. So all those in favour, please. All show, please. Okay, thank you very much indeed. So item number 5 is deputations, and tonight we do have a deputation from Jenny Shepherd. Unfortunately, Jenny Shepherd can't be with us due to ill health. So it's been agreed that Michael Lodge will read your question out. So thank you, Jenny, for the question. It's always, certainly deputations will be most welcome at this meeting. So over to you, Mike, please.
Okay, thank you, Chair. I'm starting to read it now. My deputation is about the agenda item GP services update on the recommendations from the board, specifically about the role of physician associates within the additional roles in GP practice and the plan to communicate with the public about this role. Our council is aware of the considerable uproar among doctors on medical social media about the employment of this ambiguous, medically unqualified and unregulated grade of practitioner across the NHS, including in GP practices. Will communications with the public be clear about the contentious nature of the physician associate role and about medical professionals' objections to the role? Objections from experienced, highly qualified doctors with first-hand experience of working with physician associates include: physician associates are not medically qualified, but are being asked to assess and treat patients. The role is subject to unprecedented expansion, so the assessment and treatment of patients by medically unqualified physician associates is likely to increase. Unlike doctors who are regulated by the General Medical Council and nurses and midwives who are regulated by the Nursing and Midwifery Council, physician associates are unregulated. This means their work with patients should be subject to oversight from medically qualified and regulated doctors, but this is not always the case. Where it is the case, it's arguable that the increased supervisory burden on GPs cancels out the advantages of employing the additional roles that require supervision. The driver for the employment of physician associates is seen to be cheaper costs, not benefits to patients or GPs. A BBC Panorama report last year raised concerns over the use of non-GP staff, including physician associates, within some London practices without adequate supervision. The relevant Integrated Care Board has now decided to re-tender an APMS contract currently run by the practice in question as a result of these concerns. The role of physician associates has been subject to scope creep, with physician associates taking over jobs previously done by doctors instead of assisting them, to the point where physician associate jobs are being prioritised over the work of doctors in training. This is causing friction and pressures in the workplace and placing further stress on junior doctors. Patients are being asked to see physician associates without knowing that they aren't doctors and aren't medically qualified or regulated. At least in one instance, this has been associated with the death of a patient who believed they were being treated by a GP. There is an argument that since physician associates qualifications aren't recognised internationally, their promotion in the recent NHS long-term workforce plan is due to the fact that physician associates, unlike doctors and nurses who are in high demand overseas, are essentially a captive workforce who will be unable to leave the NHS in order to work overseas. These are just a few of the objections to the role of physician associates that are surfacing in medical social media and press releases. Our GP practice has told the patient participation group they do not employ physician associates, for which I'm very grateful. How many Calderdale GP practices do employ physician associates? Why? And how do they guard against the problems indicated above, resulting from the use of this medically unqualified and unregulated role? That's the end of the deputation, Councillor Black.
Thank you, Michael Lodge. That's most helpful. We don't actually answer that in the deputation. Councillor Fenton Glynn, I think you need to declare an interest. I understand you want to declare an interest.
Yeah, I'm here in my role as Cabinet Member for Adult Services and Wellbeing. My day job is working for the General Medical Council, and the government has said that the General Medical Council will eventually have a role regulating physician associates, and we currently regulate doctors. So for that reason, it would be inappropriate for me to take part in any discussion that pertains to physician associates or their roles beyond that. So when that discussion is going on, I'm going to turn my camera off and my mute on and keep stum, because yeah, it's an obvious conflict.
Okay, thank you for that, Councillor Fenton Glynn. That's helpful to know. So we move on to item number 6, which is the main gist of the meeting. So the General Practice Report to Director of Public Health. So we've got, it's already been, the papers have been circulated. We must welcome, who will welcome on screen. I'm just going through my screen. It's all changed around. Debbie Robinson, always nice to have you on board. Equally, Neil Smurthwaite, thank you for joining us this evening. And Dr. Majid's welcome. I think that's the welcomes I need to make. So who's would like to lead on this? Debbie, would you like to start on this?
I'll start, yeah, if that's okay. So thank you for inviting us back to provide you with an update on the actions that have been taken to respond to the recommendations that you made following the deep dive into general practice in Calderdale. We've provided you with a report that contains quite a bit of detail against each of the recommendations. So my proposed approach is not to go through each individually, as I'm working on the basis that you'll have had time to read it, and I'm sure you've got some questions. That said, I would like to pick up 2 additional areas that align. The first being that primary care networks have been supported with some national funding to develop capacity and access plans. The intention is that they will be able to put focus on making some improvements to manage demand and improve patient experience of access. They're focusing on 3 areas: as required by national guidance, which is patient experience of contacting the practice, ease of access and demand management, and the accuracy of recording in appointment books. A panel which included Health Watch considered the plans from each of the 5 PCNs in Calderdale. All the plans showed evidence of actions identified to improve navigation, triage and workload management processes and or patient journeys through telephony and online contact routes. The plans show an intention to share learning across the practices within the PCNs, and they also demonstrate clear actions and many measures to monitor impact. There are meetings planned for November between the ICB, the Integrated Care Board, and the primary care networks to understand progress to date and identify any challenges. Delivery against the plans will be submitted in March 2024 with evaluation by the ICB between April and June of the same year. Finally, I just also want to recognise that following the recommendations that you made, NHS England then published its plan for the recovery of access to primary care. And I think what is helpful to outline is that it's a system plan. It's not just a document containing actions that only general practices themselves can take. The West Yorkshire Integrated Care Board will be considering a plan for delivering against those actions at its meeting in public in November. And colleagues across West Yorkshire are currently pulling this together. What is, however, very useful is that the recommendations of this board align with the content of the national plan. I'm going to stop there, and at this point, unless either Neil or Madge want to say anything, I'll hand back to you as chair for questions.
Thank you, Debbie, for that, and thanks for the update. Neil, do you have anything to add to that?
Nothing to add, Chair. Debbie's concise summary of the report. I'm happy to take questions and get into a discussion, Chair.
Yeah, superb. Okay, okay. So let's continue with questions in that case. So, Councillor Kingston, you've hit the jackpot today. You're number one.
Thank you very much. Looks like I'm the, oh no, Colin's in there now. Right, it's about the physician associates following that deputation. I did notice in the documents that you were looking for, I think it was 3 different roles, and one of them was a physician associate to take part in creating some little videos for communications, which led me to believe that it must be that we have physician associates in Calderdale, and I wondered what number of them do we have. I admit I don't know much at all about physician associates. The deputation says they're unqualified, but I'm sure that's not entirely true. They must have some level of medical qualification to do what they do, some kind of training. Could you tell me about what training it is they receive and what the breadth of their role is in the practices across Calderdale? I went and looked up Pennine Group Alliance. I see that because I wondered, I see that is in fact all GP practices in Calderdale are part of that alliance. So that I answered one of my questions for myself earlier. But yeah, could you just tell me more about the physician associate role? How many we have in Calderdale? How much are they relied on in practices? What kind of training and what level of training they've received?
So if I can just come back in terms of numbers, I don't have that to hand because I'll have to get that from the practices themselves. So I can't answer that one tonight. But I think in terms of your second question, I probably would at this point, if that's okay, Madge, defer to yourself to comment.
Yeah, no, super. Dr. Madge, would you like to come in on that, please? And welcome as well, by the way.
Hello, everyone. Thank you. Yep, that's why I put my hand up, because I thought I might be required with this one. So in Calderdale, we certainly do use physician associates. Not necessarily every individual practice has physician associates employed, but certainly the PCNs do. Again, as Debbie said, I can't tell you exactly how many physician associates are employed by the various primary care networks, but they are part of the wider multidisciplinary team. I don't want to use acronyms because I don't always know the full meanings of them, but there is specifically a wider workforce, because of course we all know there aren't enough doctors and nurses, and in fact there's funding specific, and the physician associates, as well as advanced practitioners, advanced nurse practitioners, paramedics, mental health workers, first contact physios, podiatrists, first contact podiatrists. These are all people that have been encouraged, or PCNs have been encouraged to employ, particularly to widen the workforce and to improve access, because of course a GP isn't the only person by any means who can deal with the patient's care needs. So I think that's what I'd start with. I would certainly agree with the fact that they are not qualified. These people all have a undergraduate degree, usually in science, and they then go to a university for a postgraduate qualification to become a physician associate. Locally, both Huddersfield University and Bradford University have programs and are training to a national standard their physician associates. As we heard earlier, yes, at the moment, they're working out which body should be regulating them, and we believe this is likely to be the GMC, and this is being worked upon. I think it might just head off some other questions. So if you'll indulge me, I'll just go on a little bit further. So I agree. They are practitioners who are allowed, depending within the scope of their training, to see undifferentiated patients. So they can take phone calls from patients, but they should be supervised and have supervision. So if that's happening in places, or has happened, as people are, pointing to television programs and things, well, bad practice, you might argue, happens everywhere, and bad practitioners are everywhere, but that shouldn't taint the very hardworking people who are in the service delivering a good service. Yes, they should be supervised. They can't prescribe. And they can't order investigations that impart radiation, so things like x-rays. So I can comment on how we use them at our practice and how we used in our PCN. So everybody that physician associates see are then discussed with a GP, a senior enough person in the practice to be able to, one, prescribe, but also supervise their work and assure that their work is correct, so to speak, and of the appropriate quality. Of course, CQC do inspect general practice, and as part of their remit, they look at workforce and they look at the supervision within the workforce. As we've had an inspection in the last 12 to 18 months, and supervision of our entire workforce, not just physician associates, all the other allied professions was questioned and inspected. As far as should they be introducing themselves, people don't know it's a GP. Well, people also don't know they're seeing a nurse sometimes, or an advanced nurse practitioner. Of course, that's incumbent on all the clinicians to introduce themselves when you start the discussion. And I think the understanding of what, the different professions do is important, but I think we also must recognise that we have such a shortage of workforce that if we're not finding other ways and other avenues and other clinicians and other specialisms to help within our access programs, we're not, unfortunately, in a position to just deliver this service from GPs. And then I suppose finally I might add, while some people don't like physician associates, there's actually plenty of people that do. And in our surgery WhatsApp group, we've just literally, as it might happen, half an hour before this meeting, shared an excellent review from a patient who's seen one of our physician associates, and she's gone out of her way to actually write an email thanking that individual and how well she felt the service was, and she ended it with kind of saying, thank you, and what a great idea the physician associate is.
Excellent, thank you, Dr. Marsh. Neil, would you like to come in at this stage, please?
Yeah, thanks, Chair. Just to reiterate what sort of Madge says, we recognise there are national concerns about regulation, and this is held up in government. It's not through lack of people wanting regulation. There is a faculty under a Royal College of Physicians which helps with the development of these individuals on advice and guidance. And I think it's clear in a lot of the literature, this is not to replace GPs or nurses. This is to help facilitate. It's to help bring workforce into an under-pressured service, to help do some of those things that Madge described in doing some of the basic exams, care planning, and help with it, to give GPs more time to actually treat illnesses. So it is a national initiative. There is additional funding from it. It is a choice how GP practices do it or don't. We're lucky. We do have some. Madge's practice is one that's embraced it, has worked it, and has had good results through its CQC and through its patient feedback. So there will always be hesitancy, and I think the risks are managed quite well within the system within Calderdale at the moment.
Thank you, Neil. Councillor Hutchinson.
I certainly recognise the concerns that were raised in the deputation, and I don't think they should be dismissed lightly. Physician associates have 2 years of specific training in the role. Doctors have a minimum of 5 years before they're actually let out onto the wards to treat people. And the main concern lies in them seeing undifferentiated patients who are coming along with a problem where that hasn't actually been defined fully. And these people, in that 2 years of training, don't get to know what they don't know. They don't get to know where the boundaries of their knowledge are, what other symptoms, what the symptoms that the patient is telling you about may actually be. It's not necessarily the first thing that comes to mind. And so the level of supervision needs to be really quite very, very high. And and I can imagine, well, I know that actually supervising somebody can take almost as much time as it does to do the job yourself. You hope that with experience, that will pave the way for people having a greater level of understanding. But understanding where your limitations lie is really very, very key. And not everybody gets that. And that includes doctors in training. Some of them think that they can do a lot more than they actually can. And so that self-awareness is important, but they really don't have the wide grounding in disease and its various manifestations to be able to safely see all manner of undifferentiated patients. Once somebody's got a diagnosis and they're on the way to treatment, participating in that, absolutely fine. Doing various tasks as part of that treatment, absolutely fine. But it's making that diagnosis in the first place that I do not think should be devolved to physician associates. There is also concern about the title physician associates, which makes it sound, we also have associate specialists who are very experienced doctors. That it's a confusing title, and that's where the people understanding, so that they can question. If they're not entirely happy with the consultation, they say, "Well, can I see a doctor?" Rather than thinking that they are seeing a doctor. But it's principally what they're being asked to do that gives me cause for concern.
Thank you, Councillor Hutchinson. Does anyone want to come back on that? No, Neil?
No, I will. Sorry, Chair. I think we're acknowledging what you're saying, Colin, and I think that's, Madge has been very clear that these are supervised. We are not seeing them as doctors, and nor should they be seen as doctors. And I don't think we're showing any experience of Calderdale of them behaving like that. So I get your concern and the national concern, but the fee, and Madge may expand on it a little bit more, but they are supervised. We have experienced training practices in Calderdale that supervise GP and put in exactly the same level, if not probably more, scrutiny and supervision in these individuals as well. So I'm not sure. I mean, these are national. We can't change the titles of them locally. The physician associates is what they are. It's not going to change locally in what we do, unfortunately. All we can do is provide you assurance of how they're introduced in Calderdale and how we're managing those risks and how they are supervised and how they are helping deliver services to patients. That's what they're there for.
Okay, thank you, Neil. Dr. Marge.
Yeah, so I'd echo what Neil has to say there. So they're definitely supervised, and in fact, they are supervised more than the junior doctors because every single patient they see is and should be supervised. Like we've said, the national bits, you know, they're part of the national NHS workforce plan. They're being funded to be part of that. So we're not going to change national policy and national drives. Certainly we can't. Perhaps you guys have more influence on that side of things. We know we haven't got enough workforce, and saying and being in a position to say every person can see a doctor as a GP for every contact, well, there literally isn't the workforce to do that in doctors. So I can see why they exist. They definitely have a niche. Absolutely, they need to be supervised appropriately. But you know, I would, I suppose, disagree, and I'm sure the physician associate people would, and so would the, you know, the organisations that train them, to say they aren't appropriately qualified. But absolutely, I would agree as well that, you know, people, all of us need to work within our limitations as they need to, but they do go through extensive training, both within general practice as part of their degree and lots of theory. But yes, you know, training for 2 years is going to be very different compared to training for 10 years. We know that.
Thank you, Dr. Marge. Councillor Barnes.
Thank you, Chair. I've got a number of points. Page 20, General Practice Administration. This is being worked through by CMBC officers are present. I presume at present that should have been. What does this mean? Can we have some clarity and clarification on that, please?
Okay, thank you. Debbie, would you like to come in on
that?
that?
It means I don't have an answer from CMBC on what action they've taken on this, unfortunately. I don't know whether Mike can add anything, but I have no detail that I could put in this report, unfortunately.
Okay, who's
Can I ask, is anybody actually doing this at CMBC then?
Are you asking?
There's a load of blank. I'm asking anybody because I'm seeing a sea of blank faces.
Sean's looking as though he's muted himself, so he's going to provide you with an excellent response, I'm sure.
Sorry, Sean, I didn't see that from here. Sorry.
No, it's all right. Sorry, I'm so used to Teams. I'm trying to find a hand on Zoom. No, my apologies. I'm going to have to go back and give you a response as far as that's concerned, I'm afraid. So it's not an excellent answer by any means. I'll have to get the information and feed that and find out for you.
Okay, can I just bring Mike Lodge in just for a minute, and I'll bring you back in, Councillor Barnes.
Sorry, Chair, I'm having my own problems with IT here. Councillor Barnes, can you just tell me what the subject matter of the question is, because I'm struggling to find it.
General Practice Administration, bottom of page 20, which says we recommend that requirements for GP reviews of patients that are required by housing authorities, DWP and other bodies are reviewed to reduce the requirements for such reviews.
That's about, as I understand it, Chair, that's about bodies like the DWP and others asking for a GP assessment of someone who's making a claim for benefits, or other organisations. I think that's the issue, and there is some work being undertaken within the anti-poverty strategy stream of work in the council that I checked on earlier today. It's not complete, but it is underway looking at this issue, and I've agreed to meet with the officer with my colleague from the anti-poverty strategy later in the month to see about completing this bit of work. I'm not sure it's going to be a bit of work that's completed to everybody's satisfaction, because I think a bit like the previous issue, some of these are national regulations, but the work is underway.
Thank you, Michael. Councillor Barnes, I know you have some other points to make as well.
I have a few other points to make. So the telephone switchboard facility systems, and I noticed that there's been a little bit of progression on this. Will the information, will that data be fed back up to be reviewed by the ICB, or will that just be down to GP practices? I'm being honest. Well, look, I'm continuously receiving information from people about having issues with getting hold of the doctors through the telephone system, Okay, and now I see that 4, 9, and 7 are the numbers, but you know, somebody today 49th in the queue. You know, so will the ICB be getting these figures and reviewing those figures and monitoring those figures?
Neil, do you want to come back on that?
At this moment in time, it's not a core requirement for practices to provide that to us. I think, as we've explained before, we have a number of dashboards where we assess quality. We're working with them on access, but it isn't able for us to review those numbers on a daily basis for the number of practices within Calderdale.
Dr. March.
Yeah, so I just want to say the practices don't need to report that, but we are, as a CCP, asking and working on access and capacity plans, and particularly around kind of performance around this. We've worked quite hard with our practices to get all of them on this national kind of, you know, being able to change to the right cloud-based system, and also getting the right support for them to change to get the best system possible. Practices certainly will be looking at, through the schemes and stuff, at their own performance. And then finally, I would just say number 49th in the queue doesn't mean you have to wait 3 hours, of course, because there could be 20 people answering the phones. And again, this is a nuance of some of the phone systems, because actually it might be better to switch to, you know, your average wait time is 5 minutes or 10 minutes rather than your number 49th in the queue, because they might think differently if it's, you know, you've got 10 minutes to wait on average while you're waiting. So I think you could be, you know, number 1 in the queue and wait half an hour if a practice only has 1 receptionist versus if a practice has 20.
Okay, Councillor Barnes.
Sorry, can I just come back on the access thing? Because obviously, if we're working on getting access, then surely, you know, we have to recognise that the telephone is at this moment in time one of the most important mechanisms for access for GP surgeries for individuals. I mean, we can get onto patches in a minute, and I will get onto patches in a minute. But you know, if we're not monitoring and managing and looking at that as a core element of the access to a GP surgery, surely we should.
Thank you.
We are, but the practices have got a responsibility to do that themselves. We don't have a contractual obligation for us to monitor that. We have to trust them as well to work together and to do it. And the part of the baseline and the submission in February should show an improvement.
Thank you, Debbie. Councillor Barnes again.
Well, okay. I'm not comfortable with this. I think personally it should be a KPI for the practices. I think it should be a KPI of managing and monitoring the practices. Is how patients are accessing services, and are patients being able to access services? And if patients aren't being able to access services, surely that's something that the ICB should be looking at. I'll defer. I've seen some other hands up, Chair. I'll let them, and I'll come back afterwards if that's okay with you.
Yeah, no, that's yeah, just put your hand down for the time being, then we'll come back to you. Just put it up afterwards if that's okay. So, Councillor Benton, please.
Thank you, Chair. My question, I just want to go back to the physician associates to ask a question that was a little bit unclear for anybody other than members and officers that are listening in. when the patient initially contacts a surgery and arranges an appointment, are they at that point told that they will be seeing a physician associate? And is it the receptionist that decides that they will see one of those instead of a doctor?
So basically, it's quite a bad reception, but I think the question is, when somebody phones up for an appointment, I think Dr. Madge has already picked it up, hopefully, so he's going to respond to that. Thank you.
Yeah, so as you know, we're moving away from the term receptionist generally, because actually we have kind of quite highly skilled telephone operators now, and we call them care navigators, and they've all been on specific training. And of course, remember, general practices have lots of staff who, physician associates aren't the only member of staff with what we're trying to say. And we know that our patients are being looked after by first contact physios, by paramedics, by nurse practitioners, by podiatrists. So yes, these care navigators do navigate the patient to the person they think will be most suited to deal with their problem. They're not all, it's not a default, you see a doctor always, and now you're being pushed to somebody else without your knowledge. And this, I think, has been reported on in the report that's come, that people are directed, hopefully, to the right individual who can deal with their problem. And of course, remember that when they do see a physician associate, if they've seen by the wrong person, whether that's a physician associate or anybody else, of course, it's up to that clinician to make sure they do get the right help and get put to the right person.
Thank you, Dr. Madge, on that one. Councillor Ridwan, please.
Thank you, Chair. I would just like to follow this up because I imagine a lot of lay people would not be clear, about the role of the physician associate. Now, I accept the title isn't beyond our control, but I wonder how many people would actually know that that wasn't perhaps just a more junior doctor, whether or not the idea that they'd only had like 2 years training, and the point that we've raised about working within your limitations. Generally, it takes a lot of experience to know, actually, confidence to acknowledge what those are. So I know the point's already been made, but I would suggest that I think a lot of people will be confused about this role and won't really understand it, and perhaps wouldn't have the knowledge or the confidence maybe to ask to see a GP or something more senior if they weren't satisfied with the advice they got. I think, again, probably a lot of us probably, what we're feeling from our constituents is concern about being able to access a GP, how long it takes, and are people getting the appropriate diagnosis? And I honestly feel there is a growing level of concern that I'm not really sure this addresses, because that's obviously what to most people is going to be the concern, and the sort of fear of not being able to contact anybody on the phone, having a long wait, and concern about worsening health. I wonder whether we're really seeing it from how a lot of our constituents and our community will see this. I think the final point I make is on page 21, around, I can't remember exactly, see if I can get back to it, around people taking responsibility for their own health, which always sounds great in theory. And of course, we'd want everybody, I'll see if I can find the exact wording, about putting people at the centre of their care, enabling to take control of their own health, care and well-being. Yes, of course, that's something we'd all aspire to. The reality is a lot of people are under a lot of pressure through increasing workloads, financial concerns, the cost of living crisis, all these other pressures, and they probably aren't actually going to do that. If nobody actually, for example, brings them back with a test result, they might not bother to follow this up. And as always, it will be the most marginalised communities who have least time, least access, to be able to phone and to be persistent. I can't help think the reality is that a lot of those who perhaps have less agency are just going to end up with worsening healthcare and a worse divide between a worse social divide in worsening health inequalities.
Thank you, Councillor River, on some excellent points there. I think the only caveat on that is if we tell people, oh, these people have had less training than doctors, they'll be, oh, it's a bit of a fear factor. And actually, the task that they're put in charge of, I'm sure they're more than able to deal with. So there is, I totally agree in terms of what the very valid points that you made, and I'm sure officials are equally have taken those points on board as well. Councillor Pillai, please.
Thank you, Chair. I think there's some disquiet among our colleagues on the screen that I can listen to and take note of. I concur with Councillor Colin Hutchinson and Councillor Barnes and Councillor Riveron. Some of those are common threads coming through. And I'm sure some of you know that I've spent 42 years in the NHS. And I was one of a very leading person in terms of high-powered medicine. And I was involved with teaching and guiding junior doctors with consultant support. Now, having heard all this, the NHS was destroyed by successive governments by introducing of the healthcare assistance going back in 2000 then. And that was the biggest disaster that ever was put together. Now, bringing in associate doctors or associate physicians seems to me is another measure where we're diluting the system and trying to subvert the shortage of doctors and the practices that's being under high pressure in bringing in another tier of healthcare people to fob off the general public. I, for one, who is an experienced healthcare person, wouldn't want to be tagged on to an associate physician. I want to see a doctor, and that's the person that I want. Not that my GP knows what I want when I get there to see him, and he listens to me. But some other person who's not medically qualified is going to be in a very great disadvantage. And no disrespect to what Dr. Majid and Neil have said. You both are in a situation where you have to protect and support this proposal coming through. Whoever put this goose together is beyond my comprehension. But I'm afraid the horse is bolted. The gate is wide open. None of us within CMBC are going to be in a position to change this round. I'm afraid I'll have to suck it and live with it. Thank you, Chair.
Thank you, Councillor Blair. Does anyone want to come back on that?
Thanks,
Neil,
Chair.
come back on that.
Yeah. So I totally understand your frustrations. I think, and I do agree with a lot of the national processes, there needs to be multiple roles that help with health and social care that is not just the GP. You are correct. The investment in GPs for multiple governments over decades means we do not have enough to meet the demands we have now. The people plan that was announced a few months ago by the NHS does show significant additional recruitment and training and investment in GPs and nurses, but they will take time. They'll take 7 to 10 years, and we are trying to rectify decades of underinvestment and not enough numbers. So whilst that comes through, we do have to work differently. We do have to have different expectations from a population. Unfortunately, it can't be GP does everything. So we do need physician associates. We do need paramedics. We do need physios. We do need everything to help with that healthcare and management of people in the health and social care. Unfortunately, that's the reality we are. That's what we've had investment for. Calderdale is very successful in recruiting and getting a workforce in. But the narrative of I have to see a GP, unfortunately, will have to change in the short term until things are done and a different model accepted. We have to change and react, I'm afraid.
Thank you, Neil. The only thing I would say, right, okay, I get what you're saying, but it's clear the communication out there in the public. We need to really look in terms of how we're communicating this effectively in the general public. Certainly get what you're saying. Yeah, we've got to rely on other people. Yeah, get that. But people out there don't understand this level of detail and why they're having to see that. If it's communicated through so I potentially would suggest a stream of work to saying how are we going to communicate this more effectively to the general public so that they are aware that actually they are being seen by a medical expert and it's not necessarily the doctor or whoever. So I'd firmly suggest that. Dr. Madge,
So, Councillor Blackburn, I think this is already a piece of work and is happening. I think to some degree it's been reported on in the report you've received. And I think one of the councillors mentioned that, there will be a physician associate and other health professionals that are helping us actually doing short videos and these being published. And we've got support from ICB for communications as well to kind of help explain this whole system to patients, because understandably, I take the point, understandably, there's so many health professionals now working within general practice that yes, patients should know who they're seeing, should know who's qualified to do what, and should also be reassured that this is all being done the right way with the right guidance. Of course, as Neil's already eloquently put, we're not going to change national guidance. We're not going to suddenly, generate the 10,000 extra GPs we need overnight. If indeed that's going to be government policy to want that many GPs and be able to invest that much into it. But the professionals we have, patients and population, should be aware who they are. They should be aware that they are definitely safe and qualified the job that they're being asked to do, and that they are part of the team. And in fact, if you don't need to see a certain professional and can be dealt with better by a physiotherapist, for example, than spending time talking to me, then that's the right way to go. And we need to, I think, can be able to convince the public with the right evidence that that is the right thing. And certainly communication plans are in plan to deliver that to them.
Super. No. I thank you, Dr. Maj. Certainly take that's on board, and I think it just needs to be up there. And I think I think part of, before I bring Councillor Hutchinson in, I think partly this comes to our involvement as councillors in the primary care networks as well. I think we're keen to get more involved so we can have a better understanding and a better, so we can actually, at least we are the voice. A lot of people come to us first of all as councillors, and we clearly wanting us to have the right answers, of course. Right, I will bring Councillor Hutchinson in at this stage.
Thank you, Chair. Two questions, if that's all right, on the report. Page 10 of the report about retention of staff and workforce, which is very much goes to the heart of what you were saying about there not being enough GPs. And we know from what you told us back at the beginning of the year that the training scheme in Calderdale is very popular, gets lots of GP trainees coming to participate in it, it's highly regarded, but then they go away. They don't stay in Calderdale. So it's a bit disappointing we recommended that everyone who leaves work here has an exit interview, and that we learn from those exit interviews why people aren't staying, or they may well be moving on for very positive reasons elsewhere, or they may be moving on because they don't like what they've seen. We need to know which that is, but it's still not planned to actually sort of have that process formalized, taken on board until April next year. And yet we're saying there's a crisis in staffing in general practice. Similarly, when one of the problems is the immigration issues and visas to work within this country, and you were trying to find out how many practices across Calderdale hold a license for administering the tier 2 visa system, or are interested in holding a license. And across Calderdale, only one practice holds that. Across Kirklees, 5 do. And you got a very poor response from the practices to let you know what their status was. This really doesn't give me confidence that locally we are actually trying to do what we can to improve the workforce status, to actually make sure that people who come and train here and are good, that we hang on to them. So I would like to know that, and then I've got another question on a different part of the report.
Thank you, Councillor Hutchinson. The officer seemed reluctant to put the hand up to respond. Neil.
Sorry, I couldn't find on somewhere to put my hand up. So the 2024 date is in relation to general practice staff and the work of the LMC and PGPA. I've picked up the issue in relation to the lack of progress from the support that we've asked to help with the information, with the engagement with the trainees. I think that what they've tried to do is see whether it's sourced elsewhere and then add to it locally, and they've come up against a number of barriers of getting information. So I have pushed it again this week in relation to we need to make progress on that one. So the trainees, I don't know whether I'm sort of putting Madge on the spot, because he may or may not know what the barrier is for why practices are not choosing to become to be able to do the work on the visas, which is why we're suggesting we're going to have to look at scale, because they're not putting the hand up to do it and we can't make them. So I don't know if it's because I don't know what the reasons are. Madge, I don't know if you want to add anything.
Declaring the interest as being the only practice in Calderdale that does have it already sorted, we actually had to go. It's a fair bit of work. It's not, I've got to be fair, it's not the hardest amount of work, but actually a practice having to go through sorting out, becoming a visa sponsor, going through all the legalities, it does take a significant amount of time and skill, which not all practices, certainly all practices don't have. So having said that, I anecdotally know there's a number of practices trying to do it now, but either they haven't reported it or certainly they haven't got that process signed off yet, so that doesn't exist. And certainly I'd be pushing it'd be good for us to get the numbers. I think what Debbie, I've already heard is that we're trying to kind of understand if this is something that we could help with at scale, and have either an easy guide to do so, or have some support where practices could come to and say, how can we do this, and get on it rather than doing it ad hoc. And certainly I know our practice manager has given the offer to the other practices to say, if you are interested, we'd be willing to kind of give you a noddy's guide to how we did it, and hopefully that'll help practices. That's certainly only one element of the whole process, and I know we've been through this before, Councillor Hutchinson, like you said. The issue with being a successful training scheme and attracting people from out of area is that these people go back to the area they've got their families and they're living from. So we're attracting significant people from kind of Manchester, Leeds, and a lot of these people have lives in Manchester and Leeds and then choose to go back and live there. And certainly I know we've done the discussions, and the person doing some of this work with the training scheme has had meetings with me and the training scheme and some of the trainees, and they have had some questionnaires and surveys go out. But I'm kind of agreeing with you as far as getting the exit kind of interviews up and running as fast as we'd like. Unfortunately, hasn't happened as fast, but there is a timeline on it, and hopefully it will pan out before the end of this year.
I mean, that sharing of the practical experience of becoming a Tier 2 visa sponsor does sound to be exactly the sort of thing that we should be doing at scale. And I really wish you well in getting that, moving that forward. As I said before, I think if people did come and spend a little bit of time living in Calderdale, they may see what a wonderful place it is and choose to come and live here rather than in some parts of Leeds which are flat and uninteresting. And but obviously people aren't necessarily all on their own. They do have family that may have lives themselves. But I do think we could do a better job of actually selling it here. My second question is about page 21 of the report, page 33 on the packs. One of the key selling points of primary general practice is continuity of care. And that was what made certain use to make it unique, because we have, we're constantly being told patients are more complex, they have multiple problems, and it would make absolute sense for people with ongoing complex health issues to be seen regularly by the same clinician. You recognize I'm not saying doctor there, I'm saying clinician, so that they can develop a rapport, develop trust, develop an understanding between them, and not have to go over the same old stuff each time they come. But the GP, the measures that seem to be putting, I was going to use the word flannel in the report bit, but lots of words saying not an awful lot, which doesn't give me, it does sound as if when people are making contact with primary care, wanting to be seen, that they're going to be allocated to the next available attendant, without any sort of facility to actually, for that minority of patients where continuity of care can really make a huge difference to the quality of the care that they receive, and the safety of the care they receive, and the efficiency of the care they receive, it doesn't seem to be on the menu. Please tell me I'm wrong.
Dr. Marsh.
I'm not going to tell you you're wrong, because this is a constant difficult battle we have. However, I think there are some differences, and it's not all that. So certainly those people ringing up for urgent, on-the-day acute problems are care navigated to the appropriate clinician that's available. But the chronic disease patients, and hopefully the frail and more complex patients, as you say, which are identified by the practices, do have different processes. So they do have regular reviews, whether that be annual or 6 monthly. And most practices, I can't say all practices, but most practices will have a lead in a certain area. So for example, we'll have Dr. Cleesby, who is our diabetic lead, and he oversees all our diabetic patients. Some of those need more contact, and he will continue that care. But I'm afraid it's a reflection of our current healthcare system and the way things have turned over, and actually I think it's worsened following during COVID and following it, that we were seeing a lot more routine patients with routine appointments and regular follow-ups, and actually now the way we are having to work is to respond to vast numbers of urgent on-the-day issues rather than chronic disease, and building that rapport, as you say, and that understanding with our patients and that continuity. And then finally, some of that actually has been dictated since the change in contracts going as far back as 2004. So some of this is contractual, some of this is how patients are registered, some of it is how patients now choose to access the service, and a lot of it is to do with what we are having to do, which is very reactive work the majority of the time, rather than the proactive work a lot of us would be more than happy to do.
But I would flag up to you the examples given in the Fuller report, where they discuss continuity of care, as to how some practices are managing to achieve that for those patients where it's identified to be valuable.
Thank you, Councillor Hutchinson. Neil, would you like to come back in on that as well, please?
Yeah, just to continue what Madge has said already. I think we haven't explicitly put that, but this is in all our primary care, Fuller and community strategies, and everything, and it's sort of underlined, it is inferred in everything we're trying to put in. Health and social care is disjointed across the board, Colin. It's not just general practice where there's not continuity of care. It's social care, it's acute care and everything. So that's what we're trying to aspire to as a system, by utilising all these different roles to give individuals that consistency of care and communication. But it's hard, it's difficult. I think if you remember, I think Madge alluded to back in 2004, and in 2010, the government tried to make it a contractual requirement for each individual to have a named GP and continuity of care. It failed for one reason or another, and different practices have different successes enabled to provide it. I totally agree. Providing some consistency in who you deal with across health and social care would be fantastic. But I'm also sort of in the same position of Madge. The amount of demand and need at the moment and the responsiveness that we have to be, unfortunately, means it's not able to be delivered all the time, which is why we have the variation. But it's definitely what we aspire to in all the follow and everything. It's just really hard to achieve, Colin, at this moment in time, considering the pressures post-pandemic.
If I may, Chair, I take that on board, but I would say that in the report, continuity of care is not mentioned once. And if it doesn't get, people don't actually think about it, it's going to go. It's just going to go into folk memory as to what it is. It needs to be there, as even if it's just as an aspiration, but it doesn't get a mention.
Neil, did you want to? It looks like you're going to talk on that.
Yeah, I think if we mention it, Colin, you're going to hold us accountable for delivering it, even if it's an aspiration. And it's probably one of those things that is undeliverable at this moment in time. It's something that we aspire to. Continuity at all levels, but continuity can mean different things to different people. If I take the conversations we've had today, people will want that continuity to be a GP. But the direction of travel that we're moving towards is a GP might not be the continuity you have. It might be a social care advisor. It might be a physio. That's the level that through the fuller and the multidisciplinary teams approach that we're trying to aspire to. So it's very difficult to put particular words into, our strategies and plans, because it can be dangerous to what we're held accountable for. It's not trying to escape it. It's something we're all ready to try and to deliver, Colin.
Moving towards would do. Thanks.
Thank you, Councillor Hutchins. And certainly, I still feel it's been an absolutely excellent piece of work that we did as a scrutiny, and I do understand you've taken you are taking our points on board. It's still a journey. There's still a long way to go to get to where we all want to be, and we all want to be, because we're all part of that journey. And that's what we want to, that's why we are your critical friend. We want to help, manage people's expectations and equally provide an excellent service. Councillor Barnes.
Yeah, thanks, Chair. I just wanted to come back on another point that I had that I didn't raise earlier to let other people in.
Councillor Barnes, I think there's two aspects to this. One, I think the communication, and look, we have to we accept and recognise. Hello. Yeah, Councillor Barnes, if you want to put your video off, the sound's not very good. So, but it might be better if you take the video off. Okay. Is that better? Yeah, that's much better. Yeah. I've always said I look better in a blank screen. Anyway. No comment. Well, I'm waiting for Josh to come back on that one if he's still around. I think it's just what you wanted to follow through from something earlier, and I think we have to we accept, and I think we do see that there is some progress being made. I think there's a debate as to whether we feel the progress is fast enough, and that's a debate to be had and aired. I think a couple of things that I just want to come through. I think the communication is still poor. I've had 2 messages today from residents about it who are struggling, and the communication is very, very poor. If I just use Patches as an example, the communication from my surgery on Patches was a text message. Okay, so and when I logged on, when I pressed on site to sign up, it assumed that everything was an opt-in. There was no ability to opt any of the information out. So I either opted in and accepted it, or I didn't. I think that is actually possibly and potentially in breach of GDPR, and I didn't do it. Well, that was the sole message that I had on Patches. People today are coming back who's registered on Patches
and finding that when they get to the doctor's surgery, there's no appointments booked. Or in one case, they booked an appointment with a physio and the physio wasn't there. The key issue is that is communication. The second point is this system seems to be predicated on people being digitally aware. You know, so now, you know, so we have a large, and this goes back to a point Councillor Rivon said earlier on, about those who are often in most need of requirement of GP services are often the least digitally aware, or the least able to access services that way. So I think 2 points. One, communications. I accept this has been some issue. I think there's still a long way to go on communications. But also we must, and we've said this a number of times, we must not still use digital as the first port of call. It does not suit a vast number of residents and often those in most need. Thank you, Chair.
Yeah, thank you, Councillor Barnes. I think some two excellent points raised there. I think it's to be taken on board. Yeah, totally agree on that. Especially the last one with the acknowledgement not everyone uses modern technology, and we do need to it be inclusive rather than exclusive. So I think I'm going to draw this item to a conclusion. We want to continue with the journey with you to support our wonderful residents here in Calderdale and improve and hopefully see these changes and our recommendation. I think they're absolutely excellent recommendations. Very much appreciate you taking those on board. I think they're very sensible ones that we've put together. And as I say, we'll certainly would like to welcome you back. Certainly, and timescales to be agreed, so we can receive further exciting news and updates. So thank you, Dr. Marsh. Thank you, Debbie Robinson, once again for always attending, and thank you, Neil, of course. So thank you for attending and answering to the best of your ability some of the concerns and issues that we get to hear as members. You know, and it's communicated by us. So thank you for that. So we will welcome a report and see progress in due course. So thank you for that. If you have other engagements or you have better things to do, then I appreciate you may wish to leave the meeting at this stage. But thank you for your attendance. So thank you, thank you. Cheers. Thank you, Neil. So it leads on to item number 7, care home market detailed review, terms of reference. So I'm going to lead over to Mike Lodge.
Yes, thank you, Chair. I'll be brief. You may remember that you put this item into your work programme some months ago. Councillor Pillai volunteered, perhaps with one arm up his back, but volunteered to lead on this, and we're very grateful. And Libby and myself have met with Councillor Pillai and made use of his vast experience in this field. So very briefly, we are proposing that this is the broad framework for the terms of reference. We discussed whether it would be of benefit to have a working party or the whole membership of this board, and certainly Councillor Pillai, I believe, was of the view that actually this should be one that the whole board does as a scrutiny in a day exercise. You may remember that when we discussed this previously, we thought that we would be touching on some issues that related to the business of private organisations, and so that we would get better information and have a more robust and interesting discussion by doing this as scrutiny in a day in private. But then Libby and myself will pull those conclusions of that into a report, so that as it quite properly then gets into the public arena, and the board can then choose to make recommendations to Cabinet, to Councillor Fenton Glynn or to Kath Gomali and team after that piece of work. We've put a short list of organisations that we may wish to invite to the scrutiny in a day. That is a starter for 10 and can be added to. We've kept the draft the terms of reference relatively broad, so that we've got scope to to develop this work. We've also limited it to not the whole market management responsibilities of the of Kath and her team, which would include home care, but we've limited it at this point to have a more focused bit of work on the residential and nursing home side of things. So I think, unless Councillor Pillai wants to add anything, that's all I need to say, and ask you to adopt these, and we'll move on. Libby and I will move on and make the start to make the practical arrangements.
Thank you, Mike. I concur with that. Councillor Hutchinson, please.
I do find with the scrutiny in a day, although you may be able to scope things out really well, that often once you've then had a chance to consider what's been put before you on that day, it spawns additional questions or areas that you think that ought to be explored as well. And trying to wrap it all up within one day might not be, you might not get the greatest value from it. So having the ability to have a recall or revisit on before actually producing the report may have some value.
Absolutely, Councillor Hutchinson. I think we've done it before, to be honest, where we've actually done a scrutiny in a day. We've had another meeting to actually discuss in 7 days' time to actually review and see actually do we need to do additional work on that. So yes, I very much take those points on board. That we need to have that scope before it goes into the the public domain on that.
And my other question was in terms of the care home managers, can they be skewed towards that element, that sector of the market that we feel is most fragile, most problematic, so we can hear from the people who are experiencing difficulties? It may be all of them, I don't know, but there are some very, very large care home groups, and then there's the smaller ones. So I'm not sure. I don't know which ones would be most instructive and which ones we have most concern over.
Excellent. Thank you, Councillor Hutchinson. And this is where I've brought Councillor Pillai on board, because actually he's been in that sector previously, and let's use his expertise in that field. So, Kath, if you can, if you'd like to come in, please. Yeah.
Thanks, Councillor Blackburn. It was just Jill Holbert, our Assistant Director for Commissioning and Partnerships, had to send her apologies this evening, but she did ask me to just mention that her and the commissioning team have got some suggestions and comments for the terms of reference in terms of the context and the objectives. So if I could be so bold as to forward those to Mike for consideration, is that okay?
Absolutely, more the better. Sean, I know you're off camera, but if you'd like to come in.
Yes, thank you, Councillor Blackburn. Yeah, just to add to Kath's point and to answer Councillor Hutchinson's point, we have a predominance, as probably members know, of very small care homes and care home companies across Calderdale. And that's where the greatest weakness is in terms of viability with the market. So I think it would be justified to have a focus in that respect. The bigger players, they are not really present in and across Calderdale, and the homes that have failed in the last 18 months, 2 years, have been the smaller concerns.
Mm-hmm. Thank you, Sean. Councillor Prashad. You're on mute as well, I'm sorry.
There we go. It's just an update, really. I was talking to one of the directors of TLC Care Group, who ran the retreat at Greetland. It has been sold to a major care group, so I think that one will be coming back online for Calderdale, which is good news. They wouldn't tell me what the name of the company was or when exactly it will transact, but it has been sold. So I just wanted to bring everybody up to date with that.
Yeah, can I recommend? I think a lot of the information around it's commercial in confidence. So,
Yes, it is. Yeah.
Yeah, absolutely. I was just about to mention that. Thank you, Councillor Josh Bentinglin. Councillor Kingston, please.
Just looking at it and thinking about my background as a learning disabilities nurse, that I would really like to look at specifically the care home provision for adults with learning disabilities in Calderdale, reflecting back on what Sean was just saying about that it is the smaller homes that have been affected, and certainly for adults with learning disabilities, that's the most desirable place for them to be if they have to be in a cared for environment that's not the family home. So that's problematic. I'm just looking at that. I don't know if I could be part of this with a particular focus on the care homes for people with learning disabilities.
You've just volunteered yourself. Well done.
Yes.
Yeah, super. Sean, you've still got your hand up. Are you no, super. So over to you, Mike.
Yeah, thank you very much for those comments. They were really helpful. Perhaps if we can include in the recommendation that Councillor Pillai and myself and Libby can make minor amendments to the terms of reference in relation to the comments that come in from Jill and Kath. That means that we're covered for that. I agree with Councillor Hutchinson's points that often, there are further bits of work to underway. We've done that in various ways. One is by having a second meeting. One is by asking individual members, as Councillor Kingston has just volunteered to pick up particular specific bits of work on their own and report back in. But there's a balance, isn't there, from using that discipline of scrutiny in a day where in 3 hours you get through a lot of work and you can get something sorted with having a 6 or a 7 meeting working party, which is really important for things like we did on buying our care, where we did need several different meetings, but taking on those points fully. And we'll work on getting this sorted within, reporting in the new year to the scrutiny board.
Super. Thank you, Mark, for that. So we'll move that recommendation and look forward to the scrutiny in a day on that one. So item number 8 is the work programme. I know it's already been mentioned, Councillor Hutchinson, if you would like to say something else, yeah?
Yeah, it's about the Nora Sabeel report, the Buying Our Care report that this committee produced. There were a number of recommendations from that, and some of those are attached to review within a fairly short time frame. And this is separate from the action plan that was agreed by the governance one, particularly recommendation 2 about an independent review of the cases that we heard from, and the findings of that independent review. There was a request that we should annually review the care provided by commissioned organisations and their ability to deliver personalised care, that we should review the commissioning processes of the council and the NHS locally to provide assurance that we're building religious and cultural needs into all commissioning, and that our internal quality assurance picks up on that. And there were several other things from our report that review doesn't seem to feature on the work programme at the moment. And it was to try and make sure that it can be fed in at appropriate intervals, because it was a big piece of work and it produced some very clear recommendations, and I do think we should follow through on them.
Absolutely, Councillor Hutchinson, and we'll make amendments to the work programme in that light. Mike Lodge, would you like to add?
Just to say that Kath and myself were in conversation about that, and I'm doing a bit of work to look at the recommendations that the scrutiny board made, and Kath and I are going to meet when I've completed that bit of work in October, Kath will correct me if I'm wrong, but later in the month to see that we share the same, or to make sure that we've got a comprehensive response to that, and it's exactly the points that Councillor Hutchinson's making, is that we check. I think that there's progress in various quarters on this, and I suspect that my bit of work shows there's perhaps slightly more progress than just the action plan shows. But we will look at that, and we will report back to the board where we've got on that. So absolutely, Chair.
Thank you, Councillor Hutchinson. Thank you, Mike Lodge. I think that concludes the business for the evening, and it would have been 7:15 had we started half an hour earlier, just to make you feel a little bit better. So thank you, members, for your patience in the beginning. Thank you, officers, and participation and questions as always. And I hope you all have a wonderful evening. And thank you very much for attending the Adults Health and Social Care meeting on this very autumnal evening. So thank you. Goodbye. Goodbye.
Thanks,
Thank you, Chair.
Thanks, Councillor Barbara. Bye.
Bye.
Thank you, Howard.
Thank you. Cheers. Bye bye. Bye bye.